The question from Dr. Farid.
No. Dr. Adil will answer. Or, okay.
The first one, what was the first?
Okay, Dr. Adil.
The first question, what was
the first question?
Yes, please. What is it?
What is the role of infant formula with specific growth factors in premature infant to prevent NEC?
Actually, if we cannot, the priority is the fresh, warm breast milk. If not, we go for the frozen or cool breast milk. If not, we go for donor's human milk. And lastly, the formula. Whatever the formula is, it carries the hazard of necrotizing enterocolitis. This should be the rule. We should know that the golden prevention of necrotizing enterocolitis is to give breast milk as early as possible. The first thing to go into the baby's mouth, it doesn't have to go down into the gut, is the breast milk. Few drops, for swabbing of the mouth of the baby with the breast milk every 3 hours. Breast milk contains probiotics and prebiotics, both of them, pro and prebiotics. So you are building the immunity from the first moment you introduce breast milk into the baby's mouth. I don't say the gut. You're preventing an NEC with breast milk. So please try to avoid formula as much as you can. Any comments?
Yes, if up to my knowledge, I don't know if there is a studies comparing the probiotics, or if you mean human milk oligosaccharides, which is newly added within the previous 2 years to the milk. Up to my knowledge, I don't know there is comparison between this formula or standard formula for the outcome of NEC. I don't know if Dr. Adil, Dr. Amin, Dr. Sonia know something about this. I agree with Dr. Adil. Artificial is artificial.
Breast is the best.
Yes.
Dr. Manet, do you have any remark about feeding? What's your practice in you are in the NICU?
Your mic, Dr. Manet. Your mic. Switch
the mic.
In our neonatal IQ,
we start with.
We prefer start with the breast milk, but sometimes we have a difficulty.
Yes.
In developing countries, it's not the same pasteurization and the same we have not confidence on the breast milk which we receive from the mothers who take the breast milk at home, and after we received the breast milk in the hospital, and we have no idea about the condition of the conservation of the milk, and so we prefer the breast milk, but we have not. It's not easy to manipulate in our unit, and we use preterm formula, often preterm formula. And the breast, like Professor Amin says, is the best. And to prevent NEC is the best to prevent the evolution, the outcome of NEC in premature infant. And enteral feeding, we must initiate it or started with the breast milk formula.
So I have another question that I saw it 2 or 3 times. From Professor Blibish. She's a professor of neonatology at military hospital in Tunis, and also a member of the association. So she asked about the interest of an ultrasound on a sensitive abdomen. It may bother the premature baby and be painful for him, a radiography will be sufficient. What is the interest of an ultrasound? Is it for the diagnosis, for the prognosis?
Actually,
Dr. Adel Riyad or Dr. Mustafa? Okay, Professor Adel.
Actually, he is right. The probe of the ultrasound, it may be painful for the baby. And for this, in such cases, you can use something like the oral screws just to calm him down, or even you can give him an analgesic, but the ultrasound is much more informative than the ultrasound nowadays. Although it's not, I mean, it's not becoming that much common in every neonatal intensive care, but honestly, it is very informative and it's much more better than the X-ray. It is dynamic. It can diagnose the thickening. It can diagnose the tissue damage in the intestine better than the X-ray.
Okay, thank you. So if you have seen some questions in the chat area, or if you want to ask some questions,
I have
to answer
one question about the biomarkers of NEC. This is a very good question and one of the future research area. So the biomarkers, this is involved in the pathogenesis, actually, most of them non-specific. So like to imagine like C-reactive proteins, like procalcitonin, this is help us to differentiate between the sepsis and the sepsis-like pictures without infection. So we have some GIT-specific biomarkers. This is a very good issue for early diagnosis of NEC, or suspected NEC, and for the follow-up of improvement with treatment. And also will help us to when to start the feeding. In some cases, many studies. The most specific is the intestinal fatty acid binding protein and the trefoil factor 3. This is TFF3. And the famous protein is Claudin 3 protein. This is come from the intestinal mucosa itself. However, there is something non-specific. This is released in Claudin protein can be measured in the stool. The others can be measured in the urine and the serum. Other non-specific or less specific, the interleukin 8, amyloid A, something like this. This is area of research. Can we expect or diagnose early NEC, follow-up of NEC, surveillance of NEC, and the sign of improvement? It's a very good question. Another question I read several times about the UVC, UEC, and the NEC. Actually, the UEC is sometimes accused for decreasement of splanchnic circulation or intestinal circulation. It is written the UEC in risk suspected NEC. We should remove the UVC, UEC if possible. UEC usually, if inserted, I don't know what is regular inserted in Tunisia or not, but if inserted, we try to remove within 5 to 7 days. So it is mostly not overlapped with the presentation of the necrotizing enterocolitis. UVC, there is no studies about the UVC. One I still connected?
Yes.
Yes. Now, yes.
The wrong position of the UVC can increase the risk of necrotizing enterocolitis. This was the retrospective study.
Okay, thank you. Someone asks Professor Mustafa, to write these novel bowel biomarkers in the chat area, if possible.
Okay, I can give you a link.
Yes.
I don't know if I can share paper. There is famous paper.
You can write in the chat area.
Yes, okay. I will write the name of the paper. It is very famous. You know the clinics of the seminars or the clinics of North America. This is.
Or you can send us the link to the association or to Professor Emin, and we will share it with you.
And you spread it to the audience. Yes.
This is a very good question. This is a very good question. Actually, it should be. This is the future. Also, the future is the prevention. They are talking about pathogenesis, talking about toll receptor like 4 antagonists like glutamine and L-arginine plus the lactoferrin. I don't know how to share in the chat. This is the chat.
You can send us and
okay.
When okay.
Okay.
Yeah. So we move to the surgery, Dr. Aqsia, if you want.
Yes.
I have question for Dr. I have question for Dr. Amin before the question.
Yes.
Is there any rule for laparoscope for diagnosis or management of necrotizing enterocolitis?
Thank you for this nice question. As you know, in laparoscopy, we use the carbon dioxide, and this use it to inflate the abdomen. So you can make the patient worse. And you know, the first rule in medical treatment is primary non-necessary. You should not harm your patient. So I think that this patient that are candidates to laparoscopy should well be chosen. Not this patient that are unstable can perform laparoscopy. So I prefer to not use laparoscopy, really.
Sure, this is crossed my mind during your presentation. Thank you very much.
You are welcome.
You are compressing, you are compromising the intestine with the blood flow to the gut. So it's better to be avoided. Yes. Yes. Actually, what we do is we let the pediatric surgeon participate with us in the decision as soon as we suspect necrotizing enterocolitis. From early beginning of suspicion, we call for help from the pediatric surgeon to keep an eye with us on the baby. Yes. Not to miss early intervention. Early intervention is extremely important. So it's a teamwork. It's a teamwork. I cannot say, please come to do the surgery. No, this is not my job. If I suspect, this is your intervention, not my intervention. So we have to be working in a teamwork, pediatricians or neonatologists together with the pediatric surgeon.
The scenario usually don't go like this all the time, Dr. Adel. Sorry, Dr. Amin.
So we have to be in good terms with the pediatric surgeon.
Yes.
There is what should be done. There is what. Excuse me. There is what. Yes.
Dr. Emil, you listen. So from Professor Fatma Zohrashouf again to Dr. Emil in the same idea. Do you think that the surgeon must examine the baby with the neonatologist in order to choose the best solution if surgery is indicated? And she said, it's a beautiful presentation.
Thank you. Thank you for my dear friend, Dr. Fatma Zohrashouf. So it's the same idea that was raised by Dr. Adel Riyad. Yes. I think there's what should be done and what could be done. What should be done is that the pediatric surgeon should be incriminated in the management of NEC from the beginning. This is what we were used to do in El Hada with Dr. Mustafa. Each patient with NEC should always be informed. The pediatric surgeon should be informed about the patient, because the main point is to choose the appropriate time to operate. We don't like to operate this patient very late and to lose this patient. So it's very important to look to this patient. And for me, you should see this patient every day, not wait till we have complication, or wait till the indication of surgery is clear. But I know what Dr. Fatma is wanting to tell. In some cases, the pediatric surgeon is not available or is far from you. So here the neonatologist will give the indication to surgery. But here we should discuss phone. The pediatric surgeon sometimes should move to the patient to see him, or you can have videos, we can have exchange of x-rays. It's not official, it's not really legal to make decision on photos, but perhaps this can give us solution to manage this patient. I don't know if Dr. Adel have any comments of this.
Actually, sorry, yes. I do agree. We have, if we don't have, which is extremely unlikely if you are working in a neonatal intensive care in a hospital, there should be a pediatric surgeon. But if you are in a remote area, you can share the history, you can share the lab, you can share the x-rays, you can share the progress of the baby with the pediatric surgeon, together with the phone call, together with the video call. I mean, it's the communication. Our late Professor Ahmed Sami Khalifa is one of the pioneers in hematology and oncology in Egypt. He used to say lack of communication. This is the problem, lack of communication. This is true. We have lack of communication. That's why we have to communicate with the pediatric surgeon in a way or another. We don't take the decision from our side only. If I suspect a patient with, for example, appendicitis, I should say go for the pediatric surgeon, because he is going to decide whether to do the operation or not. Because I'm not the one who's going to do the operation. He is the one to go. He will do the operation. So the final decision is of the surgeon, not the pediatrician. The same with the neonatologist. We have to have a common language. We have to have communication. This is very important. So whatever the distance, we have to transfer, to convey the data, all the data to the pediatric surgeon to help him to have an idea about the case, and then he can give us his opinion until he comes to the hospital to see the patient live.
Professor Adel or Professor Mustafa, in the same idea, do you think that a department of neonatal surgery, not pediatric surgery, surgery only for neonates, could improve the outcome of the NEC or other pathologies of the neonates, surgical pathologies?
Definitely.
I think you have that in Egypt.
Definitely.
I think you have such a department.
No, up till now we have pediatric surgeons who are becoming specialized in neonatal surgery.
Okay.
There's not up till now a department of neonatal surgery.
Excuse me, Dr. Adel. Yes, the same person, neonatal pediatric surgeon, the same person, but you know, Banha Children's Hospital, this is not belong to the university hospital. We have neonatal surgery unit, isolated neonatal surgery unit with it's isolated team. The consultant is different. It's covered by the resident of the surgeon and surgery and resident of pediatric surgery. Neonatal resident also. I think this is the only place. I don't know if each have a unit like this or not. So my unit, I cover one unit, the big units have 32 beds. We are not admitting surgery patient at all. Should be admitted there. I think this is reflected on the the team. We have more experience than us in the management, especially for short bowel, TBN management, stoma care, replacement therapy. This is different. But we have no studies about this, actually.
Professor Emin Sia, you have a question from Professor Mohsen Belghi. He says, thank you, Professor Sia. How to improve result of surgery? Is it by drainage, laparoscopy, or stomy?
Thank you for this nice question from my master, Professor Baith. I think that the improvement of the results is not the matter of the surgical technique, but more it's the matter of the appropriate time of surgery, first of all, and also the prevention. Prevention of neck and prevention of severe forms of necks. And the knowledge of the risk factors, the honest discussion between the neonatologist and the pediatric surgeon. And such webinars can enhance the communication between pediatric surgeon and neonatologist to reach this goal, to enhance or to promote the neck management, are very mandatory in the improvement of neck management. So to summarize, the appropriate time, the knowledge of the risk factors, the communications, more than the technical surgical technique or the procedure that you will choose.
Okay, do you need another question? So last question for Dr. Emin Sia for surgery. It's from Dr. Farid. From Dr.
Yes.
Farid, he asks about the number of drains to put, just one or more?
It's here also, it's a very nice question from Professor Farid Alleghi from Libya. Personally, I prefer to put 2 drains. Why 2 drains? Because sometimes you have adhesions in a part and you cannot drain all the peritoneal cavity. So I prefer to put at least 2 drains to be more sure to drain all the cavity. Especially, you do this drainage blindly. So I prefer to put 2 drains.
Okay. So Professor Mustafa, do you have a comment?
Yes, I read the questions, which is important in practice. The question was the place of occult blood screening for the neck. It is a part of lab work. Actually, the false positive results of occult blood in stool is very high, and sometimes it's misleading for us. We have many cases with anal fissures give positive blood and no neck. This is true, there is some association. One study show association between the anal fissure and the neck after that. But this is important question because I met some of our colleagues which is just do occult blood in stool and stop feeding because it's positive. And when we review the other clinical pictures, nothing, just the distension, just small residual. So it's not a part, it's very misleading. We have a major sign and symptoms of flow diagnosis of neck other than occult blood in stool. Thank you to give me time. Dr. Adel,
yes. One of the most important things to stop enteral feeding. This is a very senior decision. This is a very senior decision. This is not the decision of the most junior in the unit. To stop nurse, to stop enteral feeding, this is a very serious decision and should be taken by the most senior personnel, because leaving the gut empty will increase the risk of sepsis, which is followed by increase of the risk of necrotizing enterocolitis. So please, this decision should be taken by the most senior personnel. This is number one. Number two is I forgot, but
Occult blood, maybe.
because this is very
So I don't know what is the situation in Tunis, because usually we start feeding at morning, and the residents stop feeding at night.
Oh no, you know,
This
this
is
is not allowed at all. The Joseph Nu, Professor Joseph Nu, I met him several times, and he's fascinating. For me, I love him a lot. When we were talking about residual, he said, "What do you mean by residual?" You see, he wants to say that please do not check the residual. It will mislead you. I stopped years ago, even before I meet Professor Joseph Nu, the checking the residual and putting the nasogastric tube NGT and aspiration of the gastric content. You're doing a biopsy. You're bleeding, and then you see the occult blood in the stool, and you see the hematemesis. Please, the maximum you can do is to leave the NGT open half an hour before the next feed. Please do not aspirate the stomach. You are hurting the baby. You are doing harm. Even with the smallest syringe, they say you use the insulin syringe to minimize the suction force. Please avoid suctioning. Avoid using the aspirate to diagnose or to evaluate the residual. The concern is the bilious vomiting. This is the concern. Although bilious vomiting, not in the aspirate, because there is the antiperistaltic waves, antiperistaltic movement, which may bring some of the bile into the stomach. It will be greenish, but it doesn't mean this is bile stained. This is a sign of intestinal obstruction or so. So please, bilious vomiting, it's okay. This is serious. But the color itself alone, the antiperistaltic waves, it brings the bile into the stomach. So please be careful with the aspirate. It's misleading. That's it.
Thank you very much. So we've been here for more than 2 hours and a half. I want really to thank both of you, to thank my friend Dr. Amin, Dr. Manel for its case. We still have with us more than 130 participants. There are other questions. We can't answer all the questions. So we are looking forward to collaborating with you other times. Do you want to have الكلمة الأخيرة in Arabic?
Final comments.
I would like to say
you can talk in Arabic. Professor Mustafa and Professor Adel, we can talk in Arabic after the permission of the participants.
Okay. First, thank you very much. It was great pleasure and honor being with you. I really enjoyed it. I really enjoyed it, and thank you very much for the invitation. It's a great honor, honestly, and I really enjoyed it. شكرا جزيلا على الدعوة الكريمة. شرف لي وجودي معاكم. I really enjoyed it. أنا فعلا استمتعت بوجودي معاكم واستفدت من وجودي معاكم، وبشكركم على دعوتكم، وبشكر ابني الغالي دكتور مصطفى على المحاضرة القيمة.
تحبش بحضرتك دكتور عادل، ربنا يخليك. انا بشكر حضرتك وجود حضرتك معانا، وبشكر الدكتور امين والدكتوره سونيا للدعوه. فعلا شرف كبير لي ان انا اكون مع حضرتك، وسعيد جدا. دكتور امين يعرف معزته الشخصيه عني، انا احبه في الله. ربنا يبارك في حضراتكم، وبشكر الاودينس اللي صبرهم علينا ومشاركتهم فعلا الفعاله. very high quality of questions and interaction. ونشوف دايما حضراتكم على خير ويشرفنا دايما نكون معاكم.
شكرا دكتور امين. دكتور امين.
I would like to thank you, Professor Sonia Nouri, for the nice moderation. And of course, Professor Adel Riyad, really, I discovered a very nice person, very high qualities, scientific qualities, and very high human qualities. Dr. Mustafa Habibi, yani, he's a very dear friend. I discovered him when I worked in El Hada. He's really a very nice person. You know, he's your best friend. From the first sight, he's your first friend. And of course, my friends from the NICU, all the neonates, I love really the neonatologists. I think that they are the best doctors. They are always working, caring about the patient. I think فما بركة كثيرة يعني في العمل متاعهم. And God bless you. I hope that such webinars will enhance the collaboration between pediatric surgeon and neonatologists for the interest of these babies, because this is our last goals, is to save this patient. And I hope also that the politicians will understand this. You know, a baby that is saved would be a very active person in the future, and they are spending a lot of money, excuse me if I'm telling this, they are spending a lot of money, for some specialties to add 5 years or 10 years in the life of a person, and they are not thinking about this neonates. I think that this policy must change a little bit. Wish you all the best for the future, and I wish really to meet you physically in the future. And for this discussion, hope that this discussion will continue in the future by emails and in others webinars and in other physical meetings. Hope so. Thank you very much.
إن شاء الله.
شكرا جزيلا.
شكرا. تصبحوا على خير. شكرا، شرفتونا. عايشة.
بإذن الله. السلام يا دكتورة سونيا، دكتورة منال.
مع السلامة. عايشة.
Happy New Year.
كل سنة وحضراتكم طيبين.
كل سنة وانتم طيبين جميعا. كل سنة وانتم طيبين.
كل سنة وانتم طيبين. Stay safe. وإن شاء الله في مواعيد قادمة.
إن شاء الله. نراكم على خير دائما بإذن الله.
على خير.
Good night.
مع السلامة.